Hi, I'm Dr. Jack West, and I'm a thoracic medical oncologist at the City of Hope Comprehensive Cancer Center in the Los Angeles area.
And I'm Dr. Julia Rotow. I'm also a thoracic medical oncologist at the Dana-Farber Cancer Institute in Boston, Massachusetts.
We're here at ASCO 2023 in Chicago, where we've been seeing some really blockbuster presentations in thoracic oncology, and many of these have brought up some important questions about the clinical implications that we need to discuss a little further. The topic of neoadjuvant chemoimmunotherapy has been very hot at ASCO 2023, some new data presented, as well as some preceding this meeting in various presentations. And momentum has really shifted largely toward chemoimmunotherapy, with open questions about if something should follow that. But one of the other challenges about neoadjuvant is that there is the potential to significantly shrink cancers, and many of the patients who have been enrolled eligible for various of these studies have been a broader, more liberal criteria than many of the other pre-op or post-op trials, where we've largely limited it to at least low volume stage 3A disease and not 3B. Now, many of these trials include lots of patients with stage 3A disease, perhaps with multi-station N2 disease, potentially bulky, and increasingly stage 3B, although some of these studies use the older 7th edition AJCC criteria, others the 8th, so a little bit of apples and oranges. But one of the take-home questions, if not clear messages, is that these patients in the upper register of what we would consider maybe resectable are now increasingly being considered, if not strongly favored, to go on neoadjuvant approaches with chemoimmunotherapy. And potentially some of these are not de novo upfront great resection candidates, but something we might consider as aspirationally resectable. Like if they have a good response, they're not great now, but maybe they'll be better, and that would be great. So I have some concerns about this. We've seen in a lot of these trials over and over that the rate of resection is about 80%, not terrible, but not as high as we'd like. I mean, these patients who deviate from that plan are probably not well served compared with just starting on chemoradiation followed by durvalumab per the Pacific trial, which gave us much better results than we used to see. And it's not a terrible consolation prize. And then a subset of the patients who undergo resection have an R1 or R2 resection with microscopic or grossly visible residual disease. These are not people well served by the surgery decision. So my general question and concern is, are we being a little too broad here, particularly if this rolls out into the broader community setting with people who are doing surgery, who are not dedicated thoracic surgeons, may not be as discriminating about which 3B disease is a possible candidate or not. And frankly, a lot of our quality measures, at least in the US, suggest that a lot of these people are not meeting the mark for stage 1 and 2 resections, let alone stage 3A, 3B. And I'm concerned that they're not going to be well served. So what are your thoughts? I mean, you're at a center of excellence, but you see people from all over New England, if not the country or the world. What are your thoughts about the implications of this in terms of what we consider to be resectable disease now?
I agree, and it speaks to the challenge maybe we've had for a long time of defining what does it mean to be resectable in stage 3 lung cancer, and that varies from surgeon to surgeon and from center to center. But the important point is in all these studies, you were defined to be resectable upfront. So it was upfront resectability, like you said, not aspirational resectability. There's a real risk in extending this trial data to the borderline resectable patients who really weren't the topic of study here in these trials. To remember that we have chemoradiation as an alternative strategy for those patients who are truly unresectable, who are not going to achieve a definitive resection upfront. And this is an excellent option with the ability to do consolidation durvalumab as per the Pacific regimen, for example, This gives us the opportunity to have good outcomes for these patients, even without necessarily undergoing a surgical resection. So it's very tempting to extend this data to the borderline resectable or the unresectable, hoping to convert. That's really right now, I think, an overextension of the data.
Right.
Trials are, as always, needed in this space to understand, can we use this, which is a highly effective preoperative systemic therapy strategy to try to convert these patients, but it really should be studied again in a prospective manner.
Well, not just that. I think the issue is, where is it being studied? I mean, one of the first studies that looked at this was Nadim, which is a not a huge, it's a single arm, multi-institution out of Spain, but these are a group of institutions that are really dedicated to this and have been doing it for years. And how generalizable is that to the patterns in the US or the rest of the world, where people may not have that experience and expertise in knowing what they don't know, or the judgment of what is a strong resection candidate, and where they might do a peek and shriek, so to speak, and that doesn't help a patient if you go down this road and then have to backtrack and start new.
Yeah, I agree. We don't want the situation of patients getting neoadjuvant chemoimmunotherapy and then trying to go on to definitive chemoradiation. That's what happens if you figure out pre-op, which you want to know pre-op, but still there's a toxicity profile that's not fully understood there yet. There are studies ongoing looking at IO being added into these chemoradiation regimens.
But you'd like for it to be deliberate and
prospective.
prospective.
It to be deliberate and prospective, exactly. And same thing, you definitely want to avoid the surgical resection that is not a full resection, because now the patient has the morbidity and mortality and recovery of surgery, delay in definitive therapy without really the benefit from that strategy. So these are the situations you want to avoid. So again, it's the resectable upfront patients who can give that chemoimmunotherapy and move forward. Otherwise, chemoradiation still plays a very important role in our treatment here for stage 3.
And I think the take-home message is there is some fluidity here, but we should not be irrationally exuberant about applying this to populations where it should be very judiciously considered, and that to our patients, that surgery is not the only way to be cured, and there are other paths that can serve them potentially better. Julia, thanks so much for taking the time. There's a lot of excitement, a lot of interest in these new data, but still a lot of open questions. And I hope we continue to mull over it as we get a little more data and more insight to shape our plans.
I agree. Exciting to see these personalized therapies happening now in early stage patients.
Excellent.